Thank you very much, Jerome, our moderator, and Eddie G, Honorable Minister and Professor Feras Ibrahim Hawari, Undersecretary for Development Policy, Ambassador Ole Tonke, and Hari Kachuai Kimtai, Principal Secretary of the State Department for Medical Services of Kenya, Honorable Ministers, dear colleagues and friends. Go Iftamidai. Denmark was actually the first country I visited, or the first country I know after my own country, Ethiopia, from my visit in 1986. And it will be remiss if I don't start by saying, I wish I could be there, but I couldn't. Denmark has inspired me a lot, and especially Denmark inspired me to believe in universal health coverage. And that's why I remained a strong believer of universal health coverage. And I say all roads lead to universal health coverage. By the way, it was in Denmark in 1986 that I had my first health insurance. And that motivated me to visit or to see how their system functions. And that's where I saw for the first time how health for all, what health for all means, or how universal health coverage actually functions. So, tax Kaduhe, Denmark, and I just wanted to share this with you. And all visitors, while you have the opportunity, I would encourage you actually to see the health system of Denmark. And as a country that I respect, although I'm not inviting you in person from there, but please consider this as welcoming from me to Denmark, a country that I respect. So welcome everybody, and tax Kaduhe, Denmark, for everything and for hosting this meeting. And of course, together with Jordan and Kenya. As you know, NCD affects us all. We all know or have lost someone we love to respiratory or heart disease, cancer, or the complications of diabetes. NCDs are responsible for almost 9 in every 10 deaths under the age of 70 in low and middle income countries. And the numbers are increasing. As people live longer, as lifestyles change, as patterns of health and disease shift, the likelihood of living with an NCD increases. Taking action to prevent, detect, and manage NCDs must therefore be a top priority for every country as part of its journey towards universal health coverage. That includes in times of crisis. Conflict, flooding, earthquakes, famine, displacement, and other emergencies multiply the risks associated with living with an NCD. People living with NCDs in humanitarian crisis are more likely to see their condition worsen due to trauma, stress, or the inability to access medicines or services. The result is avoidable disability and death. I recently saw a report of 40 people on dialysis dying in one state in Sudan. Sudan has over 9,000 people in need of dialysis, over 200 of them children. And this situation is not unique to Sudan. We have seen the same needs in many countries and territories affected by conflict or natural disasters including Yemen, Turkey, Syria, Ukraine, and Gaza. And I agree with what Minister Faris said earlier about Gaza. And I would like to join him in supporting UNRWA and to those donors who suspended funding to reconsider. I believe that WHO, UNICEF, UNHCR, UN OCHA, and others combined cannot replace what UNRWA is doing. Then going to the other issues, as you know, COVID-19 was a stark reminder of the impact of a crisis on people with NCDs. But the challenge goes beyond. We live in a time of overlapping and intersecting crises, infectious disease outbreaks, conflicts, natural disasters, and the overshadowing climate crisis. The needs are enormous, but the resources are not. Less than 2% of financial assistance for health goes towards NCDs. Given the magnitude of the problem and the increasing number of threats, we must find ways of better planning for and addressing NCDs to improve health security. This means moving beyond infectious hazards to an all-hazardous approach to integrating NCDs into emergency planning. But an all-hazardous approach doesn't mean the same approach everywhere. It means tailoring our support to the context, whether the crisis is acute or protracted, whether it's happening in a country with weak governance, or in a country that hosts large numbers of refugees and internally displaced persons. Over half of those living in poverty are in countries classed as fragile and vulnerable. These same countries are host to 3/4 of the world's refugees. The vulnerability of displaced persons depends on their access to health services in the places where they come from, during their journey, and at their destination. Denial of access to prevention, screening, diagnostics, and treatment for NCDs leaves them at risk of developing advanced disease. We have a shared duty to support countries affected by fragility and conflict to deliver essential health services while maintaining their ability to respond to shocks. We have learned a great deal about how to do this. And let me leave you with 4 interrelated priorities to integrate NCDs into your emergency plans. First, it requires longer-term planning with a focus on building health systems rather than the short-term funding and operational cycles we're used to when dealing with humanitarian crisis. Second, it requires partners to work better with each other and with communities to find local solutions shaped by experience. Third, it means removing barriers to allow refugees and those displaced from their homes to access longer-term care for chronic NCDs. And fourth, it requires longer-term investments to build more resilient health systems while strengthening local governance and the social contract between citizen and state. And importantly, we need to maintain the capacity to react fast in an acute crisis. We have brought all of you here today to lead this change by shaping and strengthening our operations to better serve the poorest and most vulnerable. Thank you all for your commitment to making a difference, to making sure people with NCDs in the most vulnerable situations receive the care and the dignity they deserve. Tax Kaduhe, I thank you.